listening to Practice on Purpose, where physicians can explore how to set up their career on purpose from the very beginning to stay connected to their purpose for their entire career. I'm Dr. Nicole Eull, a health psychologist with decades of experience in healthcare, from the front lines of a level 1 trauma center to the leadership in one of the largest healthcare systems in the country. I'm passionate about physician well-being and creating mentally healthy workplaces. If you want to thoughtfully establish a career that aligns with your values and passions and ensure a long and rewarding life as a physician, then you've come to the right place. Today, we're talking about practicing medicine in the healthcare technology space. Our guest is Travis Bias, Deputy Chief Medical Officer of the Health Information Systems business at Solventum. He is currently in the Bay Area in California. Welcome, Travis.
Hi there. Thanks for having me.
We're so glad to have you today and to share your story. Why don't you start by introducing yourself with your own flavor?
Sure. Thanks. Travis Bias. I'm a board-certified family medicine physician. Been out of residency for about 16 years now. I've practiced in a few different clinical settings, but my path, family medicine is such a great specialty, so broad in scope, and my path has taken me several different places, from small single specialty practice to large multi-specialty group to employer-based practice, and now the telemedicine space. And about 5.5 years ago, landed at Solventum, which is the former 3M healthcare business. And I know we can talk a little bit about that, and also spent a little over a year in East Africa teaching medicine. So been fortunate to have taken my career in several different directions, and looking forward to having the conversation today.
I think our listeners will be very excited to hear some of the details of what you're going to talk about. So let's start with the health technology space. So how did you get into this role? What was your path to that? And maybe you could say a little bit more about what you actually do.
Yeah, sure. So several years ago, I connected with a mentor, Dr. Sarah Pastor. She's also a family physician, and we worked together briefly and had a lot of conversations about our visions of where primary care should be and where our health system should be. And she knew I was looking for opportunities to impact the system at a different level. I think it's only so long you can work in what you feel is a broken system without wanting to impact it from a higher level. And so she referred me into a consulting role within the 3M Health Information Systems business, again, now Solventum. And I've just kind of navigated through several different roles there in the last 5.5 years, it's been a phenomenal opportunity for me to learn and grow. And I think I've really learned a lot of skills in the corporate space that I would never have learned in the clinical space. So basics of like project management, change management, even some internal politics, communication and presentation skills. I think there have been a lot of things that I've been able to really learn in this corporate space that I did not realize that I would get. And so my role is kind of varied. I think I've worked mostly with product teams to help to craft solutions to improve physician efficiencies in the electronic health record. So everything from front-end speech recognition to ambient clinical documentation to computer-assisted physician documentation tools to really improve the efficient and complete and accurate capture of the patient's complexity. And so the EHR, we can talk about the electronic health record all you want. That has become a frustration point for a lot of clinicians. And so whatever tools that we can bring to improve the physician's experience within the electronic health record is a lot of what I'm working on today. And the health information systems business really spans from kind of that capture piece I just talked about on through to coding of information. So our clinical coding software that's used in the majority of hospitals across the US, and on through to our population health groupers and methodologies. So the diagnosis related groups. So these are groupers that help to risk stratify or risk adjust populations that help with payment, both in a fee for service and value-based world, and also for quality measurement and reporting.
I think this capture, for starters, is so important because I know that many people in medicine feel that they become glorified, record keepers, that they spend way more time looking at their computer and taking notes than they do actually engaging with the patient. And I also think that the EHR is really in its infancy And we forget that, I think, sometimes, that there's a lot of bumps and shakes that I think as technology advances, it really will be an asset. But right now we are the experiment. Our generation of physicians and this generation of physicians are the guinea pigs.
No, that's so interesting you say that. I will never forget interviewing for residency programs. This is in 2007 and 8, asking programs if they had already implemented an electronic health record, because I knew that was the future. And I had a program director almost lecture me. I mean, I knew I wasn't going to get into this program after the interview, but he said, there's no evidence that shows the EHR is going to improve quality of care. And at the time, I thought, this guy's off his rocker. Like, he's totally detached from reality. But now looking back, when you say guinea pigs, I mean, completely. In the last 15 years, we have been promised all of this technology that's going to improve our day-to-day, work experience. And it really has fallen short in a lot of areas. And physicians will tell you the amount of clicks it takes to do one simple task. And all of this, like, check, the check boxes we have to click, or the drop downs that we have to fill out, just to do a few simple things. The amount of clicks it takes to do that is incredibly frustrating. These are what we would call low value tasks, or even I would call clerical tasks, that really you are paying a highly educated and trained clinician to do some of these tasks. That it's incredibly frustrating. So I do think that this is a place where technology, as you say, is kind of in the early stages.
Yeah.
And as this matures, surely there will be a ton of improvements coming for clinicians, but it's been slower than most people would like, no doubt.
I think it will get better. I'm very optimistic about the potential. I think it'll get better faster if clinicians and technicians can get together closer and have a more dynamic relationship. So
yeah, absolutely. And I think there's a ton of opportunity there, but it's not like back in the paper days, we were doing a great job amassing population health data, right? It's not like we had a lot of like discrete information data points on different patients. So we didn't know where our problem points were. We didn't know where a lot of our safety and quality improvement opportunities were. And so the electronic health record has definitely improved some of these pieces, but for the day-to-day, most clinicians, that is the least favorite part of what they do.
Right. I remember working in Miami and having to go to a different building, into a basement, to look up the old records of a patient to, determine some details of the history of the case. And it, if I hadn't been willing to do that, it could have been pretty dangerous, and it's very hard to have the time for a physician. As a psychologist, I had that time, but as a physician, I mean, who has that time to do that kind of work?
But that's the irony. You just said, if you hadn't gone to look for that extra information, it might have been, lesser quality. And that was the case back in the paper chart days, where we didn't have access to all that information. So for better or for worse, the electronic health record now, there are patients who have decades of history in an electronic health record. That is an incredible, I mean, there are journal articles written on this, how much information there is for a physician to consume and understand about one patient. So now we almost have this like glut of information, have to, weed through that to find the diamonds, the pearls that really are going to impact that patient's care today. So we do, that is there now. It's organized there at your fingertips without having to go to the basement. But in a way that's almost more overwhelming for physicians. I know in residency, I would go to admit a patient, and this is going to sound terrible, but when I would see that they didn't have any record in our electronic health record, I was actually relieved that I didn't have to go read, novels about their past. I could actually just kind of start fresh, just based on what they told me, which is like not the best quality. That's not the best thing for the patient, for sure.
Listeners may come for me, but I do think that's where AI may really help us in the future to consolidate information, and then they leave it up to you as the expert to make that clinical judgment based on that. So
that has to be where AI is going to. One of the ways that it's going to help us is to summarize information, point to the relevant information, and surface that at the right time. And I think that's the biggest challenge. Is a patient who has 10 years of history in the electronic health record, how do you find that nugget that you're going to need today? And how do you find it at the time that you're actually thinking about that piece of information, or that diagnosis, or that treatment plan? That's
patterns, warning signs, all those things. So you do quite a few different things. It sounds like you're in a lot of different points of the care process with technology. So what does a typical day look like for you? Do you even have such a thing?
Yeah, I think so. There are all the some of the Instagram memes about corporate life, lots of meetings. I think there are a variety of types of people I get to meet with on a day-to-day basis. The majority of my time is spent with it is a diverse set of meetings, but with our product teams. So thinking about I'm used a little bit as a clinical subject matter expert to think how clinicians are actually going to use something. If there's a tweak to our user experience or to product capabilities, I get to kind of weigh in there. I meet a lot with our sales teams to talk with them a little bit about where the product vision is going, to educate them on how they are pitching things and how they're framing things. I think that's a big actual piece that I have come to really enjoy doing, is really shaping how we talk to clinical leaders when we're selling. And we're selling things, right? We're a vendor. But there's a way, I think, to say things, and there's a way to pitch things to really set expectations realistically that has made us such a credible partner typically. I spend a lot of time with our marketing teams, talking a lot about industry events and how we're going to position certain things, or maybe if we're writing something externally, thinking through how to frame that. And, I think that's one of the reasons I went through medical training, was to never have the same day at work twice. And that's been really important to me. I remember in high school and in college, I worked some jobs in summers and Christmas breaks, and it was so monotonous and so boring, and doing the same thing for 8 hours. And it was so draining for me that I thought medicine would be obviously a scientific based challenge. I would get to learn a lot. I would get to help people, which was all very exciting to me, but I knew I would never have the same day at work in a row twice. And that has definitely been the case in my career, and definitely in the corporate space as well. In industry, there are so many opportunities to learn new things, to grow, and I'm interfacing with different stakeholders all the time. Mm-hmm. It's fun to kind of be one of the few clinicians in a space with people who don't have clinical backgrounds. Because like you said, kind of bringing together these technologies, whether it's product experts or developers of some kind, marketers, bringing everybody together to really think through how we're going to solve things for other clinical leaders, which is really, that's actually the most fun part, is actually interfacing with clinical leaders at organizations, our typical customers, and really just hearing from them, what are they trying to do now? What are the problems they're trying to solve with technology? Is there something we can bring to bear to help them do that? And that's really the fun part, is to serve as that kind of interface between the clinical leaders at typical customers and at customer sites, and then our product teams, to really kind of help translate a little bit about kind of what we're actually trying to do here. Let's not create 100 bells and whistles. Let's create one or two capabilities that's going to strengthen our product and do something that customers really need and want.
Yeah, I agree with you. I love always having a job where things are different and you never quite know what's going to come at you. You have to improvise a little bit throughout the day. And I like to solve problems, so I think what you're doing is looking at complex data points and then taking a deep breath, providing your clinical expertise and your clinical experience also, just years of experience in the field in a new way, so you did healthcare directly, and we'll talk about that a little bit, but now you're doing it in a different way.
Yeah, and I almost see it as it's quite a similar approach to taking care of a patient, right? You're synthesizing a large amount of different types of information. You're trying to look for patterns and bring that to help take care of a patient, to really find like a root cause. If they give you 10 symptoms, they likely don't have 10 diagnoses, right? They likely have one diagnosis that's causing this kind of pattern of symptoms or issues. And so I see it similarly when I was in my first role at 3M was a clinical operations consulting role, where really, instead of diagnosing an individual patient, you're diagnosing an organization. You're assessing kind of what are the different problems. You're interviewing several people, you're doing observations, you're looking at data, you're bringing together these and trying to look for patterns and synthesizing all that to really diagnose an organization or a service line. And then similarly with technology, I think it's similar. You're looking for different kind of patterns and saying, okay, the customer is asking us for this, industry analyses are telling us this, our data is showing us this. What's like one or two things we can do to really like solve all of these? Like, how do we hit multiple birds with one stone or one new capability? And so I've seen that as kind of a stimulating use of my skills and background, but it's kind of a similar paradigm or similar way to think about doing that kind of work, I guess.
And you've said that you don't think of yourself as a health tech expert. You're more of a communicator and a translator. Is that what you mean by that? Or
Yeah, I think so. I mean, I think, there are all these formal trainings in clinical informatics now, and I'm not one of these, but I do consider myself very much an applied informaticist. As we just said, over the last 15 years, I've worked in several different electronic health record systems. I've worked with several different kind of digital applications that may help with my work. And so, but all these technologies are created, including the HR, to solve problems for clinicians, real world problems or frustrations. But if it's not usable or immediately clear to the clinician that it's going to help their workday, they're not going to use it. So I remember early days of front-end speech recognition back in 2009 or 10, I was asked if I wanted to pilot it. And I remember it took me forever just to like get the mic to work and to install the application on my computer. I'm a busy resident. And I was like, I quit. I give up. I'm no longer interested in this new technology. And so I guess I saw that I've just seen that there are so many potential barriers to adopting any kind of new technology or practice that has actually nothing to do with the technology itself.
right.
And that's where I think I see my skills fitting is the change management certifications. They will teach you all about kind of the people pieces that are required that to lead to a successful change. So for a technology application implementation, for example, there needs to be a lot of clear communication about the benefit to the end user, to the clinician. And you have to be very clear, what's in it for me, what's in it for the clinician. And ideally you just demonstrate that rather than communicate that to them. And so while I may not be I'm not like a software developer writing code, nor will I ever be. And there are some physicians that do that, by the way, which I have a huge respect for. But I've helped to build products serving a little more as a translator between like the customer leader and the product team, as I was kind of talking about, kind of going between those two teams to really clarify what is really the problem that we're trying to address. And is this potential solution actually going to address that in practicality? And perhaps more importantly, help, whether it's in the sales process or in discussions with clinical leaders, just setting clear expectations about what this technology does and what it doesn't do, and to really help establish plans for successful adoption of the technology. And I'd argue a lot of these kind of people pieces are as important, or if not more important, than the technology itself. And I think we're seeing that with some of all the new AI promises and hype that's coming out. It's very exciting. But ultimately, some of these things are still kind of one piece of the puzzle to solve headaches for clinicians.
If you, if someone's intrigued right now and they're thinking, I've always wanted to be more in the technology end of medicine, what are the things that you did or others could do to position themselves while being a clinician to position themselves to that path?
Yeah, I think there's several routes I think there's several routes, and I think that's the interesting part is there. In the kind of informatics and digital health space, you see physicians in a variety of types of roles, and you hear CMO or deputy CMO, and all those roles look very different, and those skills are very different. I think I would not have this job were it not for actual clinical experience out of residency. And I'll just be super clear about that. They would not have hired me 5.5 years ago, and I might still currently not have a job did I not have recent clinical experience, and I still continue to practice for a variety of reasons. But I think having that clinical experience and exposure is very important to then come to a team to be seen as a clinical subject matter expert. But then I think some of the technology pieces are important because the understanding integrations with the electronic health record. So how is a physician going to be using their time within the electronic health record? And if they do have to pop out to a web browser to do something, how frustrating or how helpful will that be for the physician to kind of navigate between applications? And so I think that's that kind of technology integration route is another one. Understanding kind of health system incentives, I think, is another one that I did a master's in public health, but I've worked abroad for a little bit. And I think if you're truly understanding this the incentives of the system, then you can kind of put the pieces together to understand if something's cool to a physician, that's one thing, but there needs to be a business case for the majority of physicians are employed now, so that their organization needs to see the benefits and the true business case. So I don't know if I'm really answering your question clearly.
Well,
I'm sorry, but
yeah, I think so. And I think some other things I was thinking of is that are emerging now or super users of Epic. So there's a way to become an Epic super user. Epic, for example, not to call out one medical record, but they offer certification courses to be a super user. There's usually a digital informatics committee for every hospital system. And in the previous hospital system that I was in, they had a digital therapeutics committee where it was physicians, psychologists, administrators, IT, legal, who got together and officially reviewed the research and benefits of financial and clinical of the different digital therapeutics that the different departments were vetting, because departments would vet or specialty like cardiology would vet a technology without really understanding its legal implications or financial implications, or don't get me started on the administrative load to the MA that a lot of digital therapeutics have. And so this was a committee of people who it was their business to know all of these details and to really look at it holistically to find out if it was a way to pursue. But that is a place where maybe some physicians could serve. And I believe that more and more hospital systems will have these kinds of committees.
Well, so those committees definitely, I think, are thinking through kind of, especially at larger organizations, like you mentioned, kind of how this fits into their larger strategy. I can tell you as a frontline clinician, that would have been very frustrating for me to hear early on in my career. But now I understand kind of why some of these larger organizations are having some of these committees to vet these. But to go a step further on what you just said, AI governance, this is like a huge hot topic that you may not be an AI expert or a software developer in your side hustle, but if you have this clinical experience and you understand how some of these solutions are going to be used to take care of your patients or to help with your own documentation, these are places where people with clinical backgrounds are desperately needed to weigh in and give their opinions on kind of how they see things affecting their patients and if it could negatively affect it, right? Because I think that's one of the things you mentioned, the EHR being in early days. AI is in very early days where we're just now thinking, most people are thinking about, is this going to just dramatically worsen bias in the healthcare system, which would be horrendous, or are we going to actually use this to improve health equity for somehow? And so I think really understanding what is underlying some of these technologies. What's the AI capability going to do? Is it going to predict sepsis, for example? Okay, well, that's great. Is the sepsis algorithm that was developed in patients in urban, California going to have the same impact on patients in rural Kansas or in rural Germany? There's a very different populations with very different needs. And so there are a lot of groups that are thinking through validating AI and and these applications. And so I think there's a huge need in AI governance for people with clinical backgrounds.
So to switch gears a little bit, I wanted to talk a little bit about your other passion, which is teaching medicine abroad. So what do you think are shared between these two passions?
Well, I think there were a few things that drew me to East Africa. So I taught medicine first in a family medicine residency that was getting started in Chogoria in central Kenya at Kabarak University. I was there for 4 months. And then for 8 months, I was teaching in a public medical school at Busitemi University, Faculty of Health Sciences in Mbale, Uganda, Eastern Uganda. And that was part of a US Peace Corps public-private partnership at the time. It's no longer around. But a partnership with Seed Global Health, which is a private organization that was actually trying to, I think, do something very sustainable, which was, partnering physicians, nurses, and midwives with peers who were teaching in faculty positions, the next generation of health workers in these underserved areas. And so fantastic experience. I went in, I think, with a very clear mind about what my role was going to be and what it wasn't going to be. I had a huge appreciation already for health systems, and this only kind of strengthened my appreciation for the fact that systems are incredibly important, and you have to align with kind of the primary system, which in a lot of these settings is the public health system for care delivery, as well as financing. And so I think importance of systems is number one. You said kind of how these kind of tie together. And I think too, appreciation of culture. I think whether you're working in a consultant working in a different hospital that you either didn't grow up in or didn't work in, even within the US, different hospitals have their different cultures, right? And I think just seeing that, when I go to Bustum University in Mbale, I'm not Ugandan. I didn't grow up in Mbale. I have to have a healthy appreciation for the fact that the culture is the way it is. It does not matter what you've seen in a journal article somewhere in the UK about how to practice or teach a certain thing. I think you have to have a deep appreciation for the culture, and when you're going into different settings, and without that, you're going to be hugely unsuccessful and worse, maybe offensive. And so I think there were a lot of areas where I think a generalist family physician like myself could have an impact there. So I think those are kind of the two pieces that I've continued to kind of bring forward in my career and talk a lot about and help with, the importance of understanding context in the system around what you're doing. And I teach that in a master's program at UCSF as well.
I think that's so important, that idea that learning cultural competence in any way helps you in medicine, because every discipline, every healthcare system, every city, has its own culture. And if you learn those cultural competence skills, they really help you to adapt quickly and to understand the rules of engagement in that culture. So
yeah, absolutely. Early on in Uganda, one of my first few days there, I'd come back to the States for a few weeks after my Kenya experience, and before I switched programs to this program I was going to Uganda with, and I needed a SIM card for my cell phone, and so I went to the mall, and I had like an hour between sessions in my orientation that was in Kampala. And I was in a rush. I took a boda motorbike, to the mall. I jump off, I run in, and I walk right up to the person at the mobile store who's sitting there. No one's in line. And I said, "Hi, I need to buy a SIM card." And they stop and they go, "Hi, how are you? How's the day?" And it was kind of like all right, like calm down. Let's talk about the day a little bit. Let's do some greetings. And even in the medical school, the expectation, you sit and you have some tea. A meeting is not just let's get down to business and knock everything out in 15 minutes. And so I think the more you understand those and participate in those, by the way, your own experience is much better. But that's how things actually get done. And so I think that is a frustration for people working outside their home culture, but it's something that has to be understood and appreciated.
I think there's some large amount of nurses who'd appreciate doctors cultivating that skill of learning to check in and take a moment to connect interpersonally before.
I'll never forget working night shifts in residency, and I had I was in medical school, and a upper level resident. It was the middle of the night. Things kind of slowed down a little bit. He's like, "Come on, we're going to go on social rounds." And so we went around. He visited some of different nurses on different floors. He was checking in a little bit on his patients, but making sure that the senior nurse he was monitoring one of our ICU patients, and it was just kind of this almost like team building, team camaraderie, rapport piece that I love. And there are a lot of places, you're right, in medicine and nursing we don't have. There just doesn't seem to be time for it right now, which takes a lot of the joy out of the work for a lot of folks.
I love that idea of social rounds. I think I'm going to feel that.
I still think about that fondly.
Still practice. What does that look like for you in the midst of this very busy and demanding other job that you have?
Well, so this is the beauty of telemedicine. I think that the pandemic really dramatically increased the availability of telemedicine. And I think in 2020 saw telemedicine done well. I think a lot of quality primary care can be done virtually. And I've now done telemedicine visits for a few different platforms, and I have seen this where you can do it well and really improve access for patients. There are patients in rural California who couldn't find a primary care physician, yet I could safely refill some of their chronic medications because they were, very well educated, monitoring their blood pressure, blood sugar, what have you, that I thought I could safely do virtually. And so, I do that kind of evenings and weekends, basically. Try to, 8 to 12 hours a week, depending on the week and what that feels like. And now I have 40 state licenses. Don't get me started on the licensure issue, but that's kind of the currency in telemedicine world.
Yeah.
I guess, but it's nice because I get to continue to, interact and care for patients, which it's, when you're in the technology space, or when you're in a space that's like a little outside it's not comfort zone, but it's a little outside of what you've trained to do for many years. It's kind of nice to feel like competent in something, fully competent, to really and just to connect with, I'm an empath and an extrovert. And so during the pandemic, I'm stuck at home. And so it was actually nice to connect with patients and feel like I was actually serving a need. So that it's all telemedicine right now, but there's so many more platforms that I think are coming up and trying to do this the right way. Multiple people that are trying to find the right way to apply telemedicine to really improve outcomes and access.
So tell us about your interest in writing and health diplomacy.
Yeah, so I've been drawn to the field of health diplomacy ever since learning about it in my master's in public health from Dr. Rebecca Katz. She was at George Washington at the time. She's at Georgetown University now. But this concept of leveraging diplomacy to improve health, or leveraging health programs to actually improve relations between countries or between entities. And I think that just kind of fascinated me because I saw how important relationships were, back to social rounds, that how important these relationships are with patients and at the organization level between all these different stakeholders to get things done. The classic example in health diplomacy is how the US and Soviet Union worked together in the late 60s to help eradicate smallpox. And this was at the height of the Cold War. And so that kind of concept that if that kind of work is possible, then really anything's possible.
Yeah.
In the event of a global pandemic, let's say, if we really want to apply ourselves and work together, then we just need to kind of see those possibilities and act on them. So I guess all those strengths, the things that we talked about previously, where I think I can bring strengths or skills to the table, such as communication skills or translation skills, building rapport, like we mentioned. I guess I saw that as really lending itself to being a diplomat, I guess I would say. And, who's a health diplomat? Well, there are formal health diplomats that work within the country's diplomatic corps, that maybe work at multilateral organizations like the World Health Organization or World Bank. But, sometimes I guess I think about who those diplomats are and who the messengers are, who are the representatives. And I think the messenger sometimes is actually as important, if not more important, than the message itself. And so I think physicians, we use a certain language and we bring a certain background and approach to things that I think is well received by many different audiences that can really establish. Really all kinds of health workers can bring this type of approach to relationships, and really we can convey messages that establish trust and rapport that can be incredibly valuable in many situations. And so I don't know if this is a bit outside the box, but so in the fall of 2016, I actually took the Foreign Service Officer exam at the U.S. Embassy in Kampala, thinking that I'm working in Uganda. I have this certain background and interests, like I'm going to be a diplomat. I passed the exam, but I never got invited for the oral interview. Of course, I blame it on the fact that there was a hiring freeze in the State Department at the time, so I'm just going to blame it on that. But
sure.
So while I'm not like a diplomat in the traditional sense, I still am getting to do that kind of work and still think I'm actually on the path to this. Even last week, I represented Solventum at International Trade Administration roundtable on AI-enabled medical technologies. And so I think there are ways where a clinician can be a credible representative in kind of diplomatic, I guess, conversations. So this field, I think, of health diplomacy is very new. And I think there's nothing like a COVID pandemic to show us how important relationships and countries and organizations really working together on such areas like equitable vaccine access, for example.
Yeah.
So it's an exciting field, and I've written a few things in the area and hope to do more, I guess.
So aside from working in healthcare technology, having a clinical practice and writing, you also have another time-consuming and exciting thing in your life. New. I believe you have a small baby.
Yes. Yes. She's,
So how are you finding balance with all that?
yeah, my wife, my partner, she and I, we talk about this a lot. It is really, it's a life changer having a
Mhm.
baby.
Yeah.
So she's 6 months old now. She's sleeping through the night like a champ. She's amazing.
Hooray.
Yeah, no, life is stabilizing for sure. And she's so amazing. But we have talked a lot about sustainability in our careers for a long time now, and what balance looks and feels like. I think sometimes technology makes me feel like I can do a lot more than I actually can in a day, as far as like the draining cognitive task switching between these different tasks. So I think having a daughter has really made me think a lot more realistically about, all right, what is sustainable? What does balance look like? Because I do want to have uh, time to spend a lot of time with her, actually, reading to her, playing with her.
Right.
And that will obviously change as she gets older, that what's demanded there. And so I'm super excited to seek that out. I think that's one benefit of being a mid-career parent, is that, I've gotten to a certain place in my career now to where I do think I can find balance, but that's, I guess, a continual challenge for any of us.
Yeah. And I think once you figure it out, they change developmental stages and then they need something different from you and you have to do the math all over
Yeah,
again.
that's no, that I've definitely learned that, once you have a few days of something awesome, you just like enjoy it,
Yeah.
appreciate it.
So a few closing questions I like to ask everybody, and they're a little different this season. What is one piece of advice you would give to an early career physician?
Well, I already talked about the sustainability piece. I think it's very important for your path to be sustainable, and especially if you're working anywhere outside your home culture. I think whatever your work you're doing needs to be sustainable for your host, but also sustainable for you personally.
Mm-hmm.
And so I think a lot about that. But I think the big piece of advice, the reason I've been successful in many areas, is I've been told I'm a doer. I'm willing. I'm a pragmatist. I'm a family doc. I'm willing to kind of jump in and do things,
Yeah.
and I do my best given the time constraints. And build your own PowerPoint slides. Go get breakfast for the team. Be the team player that people want. And I
Yeah.
think that is a key thing, that even if you're a subject matter expert or seen as that on the team, you still need to play an equal role. And I think that's incredibly important. And I guess to say yes to opportunities. I mean,
Sure.
there are a
Yeah.
lot of things that I think we don't think we're qualified or ready for, that if someone's
Exactly.
giving you the opportunity, you probably are.
Yeah, it's funny you mentioned being a doer because I remember being in a committee once, and at the end of the meeting, I was like, "Okay, what's the deliverable? When are we gonna do this? What are our
Sure.
goals for this year?" And the gentleman who was leading the group said, "Well, I can see that you're a doer," and I don't think he meant it as a compliment.
Yeah.
So I've learned to find people who appreciate that I'm a doer as well. So
Yeah, I mean, I think that's right. I mean, there's certain settings where that's maybe not valued, and maybe that's not a fit for you. I think
right,
that's the thing I've thought a lot about. There are a lot of places where it needs to be a fit for both parties, your
right.
employer or whoever you're serving or working for, and for yourself. And I thinking about that bidirectional fit is key.
So, is there a piece of advice you would give to your own younger self?
I I I, th- I guess I think back to my days in college, and I think I would tell myself maybe not to take things so seriously. I
Mm,
don't I you know
I think that's good advice.
yeah, I mean, I was such a serious, pre-med, and I was, on the path, and I I mean, I had plenty of fun. Let's not, I mean, kid anyone, but I think sometimes we take things too serious. And I think ultimately, if you are working towards your mission and staying true to your values, you're going to have a rewarding career.
And what are you loving about medicine right now?
Well, I think what we've talked about as far as being in the early stages of things, I think when you think about telemedicine and digital health capabilities, and really thinking through how we're going to apply these to actually help populations, I
Mhm.
think that's very early days, and definitely in the AI regard, we are super early days when it comes to using AI. You see a lot of hype and promise out there, but I do think we're still super early days. And to me, that tells me that this is the time to really shape where this is going and to be very clear about what we're going to be doing with this technology and what we aren't, right? Like I saw someone on stage recently say that the FDA was going to clear an app to practice primary care in the next 5 years. And I thought, well, that's well and good, but there are many patients I know that don't want an application to tell them they have breast cancer, for example.
Right.
Let's use a lot of this technology to identify that breast cancer to help surface the exact right treatment for that patient. But they're going to want a human that they have a connection with to deliver that result and to maybe talk through some of the options. So I think there's a huge role for technology and AI to expand access to information, to surface and summarize information, as you mentioned. But I still think there is going to be a clear role for human health workers of all types. And we just have to be very clear about what that human role is going to be, leveraging the technology. And there's no one like health workers to help shape that future.
Yeah. It'd be amazing if the app would focus on the mundane tasks that fall to primarily primary care physicians, like disability forms, filling out the parking form and the tag for your, handicap parking, and writing the permission to your teacher. It's back to school and the work disability leave. If we could get an app to take care of all that stuff, I think then doctors would have more room for the real.
Yeah, that's right. Those are those administrative low value tasks that many of them low value that, once you've decided you're going to write a return to work note, the amount of time in some systems to just produce that is incredible. And so, and what you mentioned, like the placard or like disability forms with the state, any state that you're in. I mean, there's a lot of pieces where absolutely AI and technology should be able to handle much of that. Then you use the health worker, the human in the loop, to review that and sign that.
Yeah. So what's next for you?
Oh gosh, I don't know. Being the best partner, husband, and father I can be, I think is number one, and I'm very excited for that. It definitely changes things. I think I don't really know. I've constantly tried to put good things in my path career-wise that then set me up to be ready for that ideal job. I don't know what that ideal job is, but I once heard Mark Dibble. He was the first head of PEPFAR, the Office of the Global AIDS Coordinator, and he was the first Global AIDS Coordinator, and he gave a guest lecture in one of my master's classes, and he said, being at the head of PEPFAR, which was a young program at the time, he said, 30 years ago, my job didn't even exist.
Right.
And that just excited me, just hearing that concept and thinking about that. And then when the COVID pandemic came along, I thought, wow, there are so many different roles in the health system that I think we're now seeing how critical those really are. Yeah. And so I guess I take comfort, and it makes me a little more patient with my career to say, you know what, I'm learning and growing, contributing the best I can to improve our system. And ultimately that dream job will come along. So.
Okay. And we have it on recording that you're going to be the best dad and best husband you can too. So
that's number one for sure.
Now we've committed to that. So thank you so much for your time today and sharing your path and your unique career. And I think there's a lot of people who will be very interested in hearing about that and just opening up even more possibilities for what people can do with their medical career. Is there any place where people can learn more about you that you would like to mention now?
Well, I guess I'm using LinkedIn as my home base, to be honest with you. And so that's a place where I'll share kind of any writing or any thoughts about a variety of topics that we talked about. And obviously the Solventum website, we have I'm a co-host of the podcast there. Okay. And we have our own blog and things, so they can read a lot about kind of what our experts are thinking and seeing in this space.
Okay, super. So thanks so much for joining us on this chat about healthcare technology. We hope this show has you thinking about your own career and what action you can take to make it ideal for you right from the start. If you've enjoyed this episode, please like and subscribe and tell others to join us. We greatly appreciate your reviews and comments, which help us to grow to a wider audience. If you want to stay in touch, email me at practiceonpurpose@heyinfluent.com. Let me know what topics you want us to explore in future episodes. And remember, build your practice on purpose to stay connected to your purpose. I appreciate you joining us on this journey. Let's keep exploring together. Until next episode.